Good afternoon. This is Kathy Duncan. I am a director at IHI, and we are so excited that so many of you signed up for this webinar, and we're so excited that you've joined us here this afternoon. Just a little bit about me. I'm a director at the Institute for Healthcare Improvement. Before that, I worked 23 years as in an acute care hospital in Memphis, Tennessee. And most of that time I was in management and operations, and then leaving there as the director of ICU, orthopedic, and neuro. Since I've been at IHI, I've had the opportunity to work on a lot of very exciting projects. I had a lot of activity with the 100,000 Lives campaign, the 5 Million Lives campaign, Project Joints, and many other clinical expeditions and webinar series. So I've been with IHI for 13 years, and I'm so excited about our webinar this afternoon. Just want to let you know a little bit about this afternoon. Before we get started, I want to say a few words, just a bit about the Better Care Playbook, which was developed by IHI with support from many other good folks. We had 6 foundations: the Commonwealth Fund, the J.A. Hartford Foundation, Millbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. The playbook, which you can visit at any time on bettercareplaybook.org, highlights many promising approaches to improve the care for the people with complex needs. During today's discussion, we're going to have the opportunity to hear from several experts, and we'll be exploring a very interesting topic, really thinking through and highlighting various things from the playbook in trying to improve the care for all of our patients with complex needs. During this webinar, you can submit questions at any time through the Q&A button on your screen. It's at the bottom of the screen. You can submit those questions, and we'll get to them shortly. So first of all, I'd like to introduce our panelists, and I'd like them to say just a few words about themselves as we get started. Mary Naylor, Dr. Mary Naylor, is Marion S. Ware Professor in Gerontology and the director of the New Cortland Center for Transitions and Health at the University of Pennsylvania School of Nursing. Susan Reinhart, Dr. Susan Reinhart, is a senior vice president and director for the AARP Public Policy Institute and a chief strategist with the Center to Champion Nursing in America. And then last, we have Sarah Stratton, Dr. Sarah Stratton, Health Equity and Social Justice Endowed Professor and the Director for the Innovative Care in Nursing. So now I'd like to turn it over to our panelists and give them an opportunity to briefly set the stage for our conversation. So Mary, can we start with you?
Yes, thanks so much, Kathy. I am absolutely delighted to be a part of this webinar and to join my great colleagues, Sarah and Susan, and I'm very grateful to the foundations for their investment in highlighting the evidence around how it is that nurses and other team members can improve the care and outcomes of older adults. My perspectives are very much influenced by more than 2 decades of working with a team at Penn, really focused on thinking about what it is that we can do to better galvanize health and social services to meet the increasingly complex needs of a growing population of older adults and their family caregivers. The other part of our work that I think is really important is that we've had the great fortune with the support of payers and purchasers to work on the ground with nurses in hospitals and health systems throughout the U.S. and beyond to think about how we can move this evidence into practice. I think the playbook represents a tremendously important tool to advance access to the kind of information that we've been developing, our team and teams throughout the country and indeed throughout the globe, making it more accessible to nurses as they think about how can we do something today faster than we've ever done before that's grounded in rich evidence. So I do want to end this introduction by saying I'm so delighted to have gotten to this point where nurses and what it is that they bring to teams in managing complexity has never been more needed and more recognized. So thank you for this opportunity.
All right, thank you so much, Mary. Susan, you want to help us set the stage here?
Sure, Kathy, thank you. And hello to Mary and Sarah. It's always great to be with them in any capacity. So you heard that I'm with AARP now. Just a background, I started as a visiting nurse just a few months after I graduated from nursing. And that brings you into the homes and communities of people, which automatically makes you aware that it's not just healthcare, but it's health and social needs, especially for people with complex care. So that is my perspective all along. It is great to be at AARP. I imagine most people know what that organization is, but it is an organization of close to 40 million people who are 50 plus, and they are often the patients with complex care that we're talking about, as well as their family caregivers who are called upon to assist with that care. So I spend a lot of time in the area of family caregiving, in nursing, and often bringing those two together. You heard that I am a chief strategist for the Center to Champion Nursing in America. That is a fabulous organization, I have to say, funded by the Robert Wood Johnson Foundation, which, as you know, is one of the key funders of the playbook we're talking about. And our focus there is bringing nurses more into building a culture of health, which is complex care, health and social needs. And I can talk more about the specifics in working around the country with 50 different action coalitions of nurses and their colleagues outside of the nursing profession to make that happen. We also do a lot of work, as I said, in family caregiving. We have programs and research funded by the John A. Hartford Foundation, also a funder of this work, and others, the SCAN Foundation, others that I can get into that have been tremendously supportive of the idea of how can we help nurses better support family caregivers who are providing complex care to those in their families, their neighborhoods, their friends. And we also are founding members or funders of the National Center for Complex Health and Social Needs, located in Camden, but creating a whole field across the country. So if anyone's interested in talking more about that, we can do that also. And just one other thing, we have started to look at AARP Wellbeing Champions. These are people who are 50 plus who are in this world of trying to promote a culture of health. We have 10 of them now, and we are actively bringing them into both the AARP worlds and the nursing worlds to highlight what they do, like in housing, homelessness, transitional care, a la Mary. So I'd be happy to expand on any of that.
All right, thank you so much, Susan. Sarah, can you help get us started?
Yeah, and thank you so much for allowing me to be part of this. And Susan and Mary are two of my favorite people who I respect so much. So I'm really thrilled to be on the same platform with them. I'm Sarah Xanten, and I'm a nurse practitioner. My first nursing job, just reflecting on what Susan said, was with migrant farm workers. And then my second one was with people experiencing homelessness. And then once I was a nurse practitioner, I did house calls with older adults who were homebound, either because of their body or because of their environment. And the thread throughout those is seeing the complex environmental needs of people. Some of the migrant workers were living in adapted chicken coops, literally. And seeing the ways, I think as nurses, we are trained and we see the ways that the environment affects people and their families and their complex chronic and social conditions. And so together with others, we developed a program called Capable for low-income older adults, specifically to get at the environment and the person around what matters most to them. And I think everyone probably on this call agrees that the most important, M in medicine and nursing is what matters most. Not what's the matter, but what matters to you. And we've been able to show that we can save 10 times what our program costs by addressing the person and the environment based around simple goals like people saying, I'd like to be able to take a bath by myself. And then what are you doing about the pain or the depression or the bathtub itself or your energy conservation to get to be able to do that? So I'm thrilled to be part of this overall discussion, and thank you.
Well, thank you so much, ladies. Now we're going to have the opportunity to hopefully reach out to you and let you ask us some questions. We would like for you to take the opportunity at the bottom of your screen to write in some questions there for our panelists. And I'm going to see if I can get started just quickly here with a question for Mary. Mary, we've got a lot of solutions. We've got a lot of things that have been going on and that have been helping us with addressing complex health and social needs for our patients. But it's been a really sort of slow uptake of actually getting the work done or actually taking up the evidence that we have found out. So I wonder why that is, and what is it that we could do as a community or as a group of nurses to really accelerate these approaches and really get them out there so that people can be using them.
Is exactly what the playbook is doing. It's making evidence that we publish in really top-tier journals accessible, information available to the nurses who want it to be able to deliver high-quality, exquisite care to very complex people. And so just getting it in a form that people can use in a meaningful way to take care of Mr. Smith or Mrs. Jones, I think is exceedingly important. You know, the work in transitional care, we've shown in multiple NIH-funded clinical trials that this approach to care, the transitional care model, when compared to all available evidence and other standards, does better, gets us to better care and outcomes. But it's been a very slow journey of providing people and systems with the tools and information that they need. I think we've advanced tremendously, but we need to continue to push access to this. Our own nursing education systems and sometimes our own practice environments have been slower to embrace newer approaches or position the current workforce, emerging workforce, and practice environments with the tools and resources. So I think that also is changing, but we need to continue to accelerate. And finally, I think we do have something going on right now that represents a huge opportunity. Incentives are changing. The financial incentives to get to better care for the population that is rapidly growing with a shrinking family caregiver workforce. And so movements toward higher value care, toward population health, those efforts, I think, are going to really dramatically improve. But we need still to do everything we can to make what we know as better care much more accessible to those critical frontline clinicians.
All right, thank you so much, Mary. Let me just remind you that you have an opportunity to send a question through the chat. We did get, or through the question and answer, excuse me. We did get a question thinking about what opportunities exist for nurses to partner with private industries to advance the playbook.
So this is Mary. I didn't know if you wanted to move it on, but we are working very much with a wide range of stakeholders. We had Penn School of Nursing hosted a think tank earlier this year through the Center, New Cortland Center for Transitions and Health. And we brought together people from all sectors, the private sector, public sector, to help us think. And there's tremendous interest within the private sector about using evidence to accelerate the mission and goals of these industries. So thinking about how we can directly engage the private sector, those that are really partners with us in trying to get it better for everybody, providing them with information toolkits about the evidence, adapting it in a way that is meaningful for them. I think there's tremendous opportunity for colleagueship, collaboration, and spread of evidence.
And I would just add on to that, there's so much movement in terms of tech with artificial intelligence and robotics, and there's so many possible solutions, but they need clinical input and human-centered design in terms of both nurses and other team members and the older adults and people with complex chronic needs. And we shouldn't shy away from getting involved in those efforts.
Yeah, that's great. I think, and great thoughts that you, Mary and Sarah had. So we could begin to really do that in our own communities, get industries in the private sector, and introduce them to what it is we're learning and how to use the playbook. Any other thoughts?
Well, just in general, this is Susan. Nurses historically have been grounded in teaching and in working with people in a holistic way. But over the years, we became, as the whole system did, a very acute care focused. So it is incumbent upon nurses, and we are committed here at ARP, the Robert Wood Johnson Foundation. I know my colleagues on this panel are committed to helping bring nurses back to the future, I guess you would say, so that they can be more population health focused. So for example, we have something going on right now with Robert Wood Johnson Foundation to put population health curriculum, population health and nursing into the curriculum across the country. And we're starting with some, key players like Oregon, for example, that is doing a good job. And then work with other partners across the country to bring that into mainstream nursing. It's not foreign to nurses. It's more of okay, remember this? Let's see if we can pull it back into our identity and our skill set. It also means that health systems have to give us the time and the support to be able to do that.
Well, you're exactly right, Susan. It seems like we're coming full circle here with nursing, but most nurses, or the nurses that nursing in general, that's what we went into nursing to do, was to take care of the whole patient. So beginning to learn more and more about the opportunities to do that, and learn more how we can help the whole person or the whole family or the whole community in population health. So thanks for that. Any other thoughts?
Well, you mentioned family, so I mentioned that earlier. One thing we are trying to do is to help nurses in particular, but in general, all professions, really think more specifically about family caregivers in health. And by the way, in hospitals also. We have done research on this. We call it home alone, meaning that people go home and there's not as if a visiting nurse is waiting for you at the doorstep with a home health aide or something. You're generally on your own and expected to perform very complex tasks, medications for sure, but also wound care and special diets and technology, as Sarah pointed out, lots of different things. And we found that about half of family caregivers are expected to do this, but are not given the kind of teaching and guidance and support that they need to do that. So we are developing videos and resources and ways to help spread the word and get that out.
So good. So let's move on to our next question. We had a question come in, really talking and starting, setting the stage with, there is a lot of similarities between the pediatric complex care population as well as the older folks with complex care needs. Not necessarily the diagnosis or the actual diagnosis, but really thinking about the healthcare utilization, the home, the caregiver burden, and the social aspect of the care of that patient. So often advances in innovations of systems of care occur first in the adult world, and they may trickle down to pediatrics. Can the panelists comment on what the pediatric practitioners excuse me, what the pediatric practitioners are learning and can learn from the adult world and in regard to complex populations and discharge care?
Sure, I'll start with that. Just building off of what Mary mentioned earlier, as the financial models move from fee-for-service to paying for value, there's a lot of in common across the age span for complex chronic conditions, where if an insurer or a payer knows that someone is going to be expensive to them in a predictable time period within a year, say, then they're more likely to be able to invest in making sure that they have housing stability or that they have enough food and other things that other people might not have thought of as medical prior, but now we all realize that it's to the bottom line of insurers. And so that people with complex chronic conditions, in a way, you have more wiggle room for being able to invest holistically, because they will predictably cost money to the system, and so better to put some prevention money in.
Yeah,
I was just going to say that I really think that the adult world has to take lessons from the pediatric world, and so that's good. It should be mutual, right? I'm just, for example, the family nurse partnership work that has been done over the years that has such incredible evidence is nurses going out into the homes, working with young, new mothers and fathers to teach them how to care for someone and stay with them for a while, not just like a bing, bam, boom, a couple of visits. And they do integrate families so much, as opposed to the adult world where we're struggling really hard to get the family included. So we have lessons to learn both ways.
Yeah,
I was
thought.
going to say, we started our actual work in transitional care based on what was going on in the pediatric world. The transitional care model had its roots in working with families of very low birth weight infants. And, what we figured out is exactly as the person who raised the question, there's common ground in vulnerabilities. The challenges that individuals and families face, whether they're very young or very old, are often rooted in a whole set of issues that we have not traditionally paid as much attention to, but now we know are critical. The social determinants of health, understanding what it's like for families to be able to take care of people with very complex needs, what kind of financial impact it's having on those families, what it's like in terms of being able to access the resources that they need in a timely fashion. These are common ground challenges, and it really points to, what I think this playbook and the evidence is all saying. We've got to galvanize health and social resources in a way that to meet the individualized needs of very low birth weight infants, chronically ill children, adolescents, and older adults and their family caregivers.
Yeah, great. So one person asked a question, and we're going to try to put you on the spot here just a minute. If you had to pick one or two actions, one or two now, what are the most important changes that primary care practices could make to meaningfully improve the care for their patients with complex conditions?
So I'll start. I think partly it's a mindset of getting beyond the visit, I'll just say the initial visit, which is often triggered by an acute exacerbation of a chronic condition, or maybe something like a fall or something that has happened, into thinking beyond that. What's going to happen when this person leaves? How are they going to manage this condition, which is often multiple conditions, outside, back in their homes, and who is around them that is going to support them? That's a lot, and I know that primary care visits are short. So what other resources can be added to that mix to help primary care professionals be able to accomplish that?
So beyond,
Go ahead.
I was just going to say, beyond building on Susan's idea of going beyond extending the walls of primary care, so the mindset that it is what happens in an encounter rather than what happens over a period of time. I think it really is thinking about how care by a team can be operationalized in a meaningful way. And the team is not necessarily the people we all only think about, physicians or nurse practitioners or social workers or nurses, but going beyond that to include what Sarah, I'm sure, will talk about, but other players in the community health workers, others, to really think about how is it that we can collectively together align with what matters to the person and their family caregivers, their goals, their preferences, their values.
And I would add two things. One is, in pediatric visits, when your child is 2, they say, they give you a handout. This is what you might expect. It's common for them to say no a lot, and they'll be trying to do everything on their own. And we don't have that in aging because it's so heterogeneous, right? An 80-year-old might be running a marathon, or might be homebound, or might be somewhere in between. So you can't say, okay, this is what to expect. But on the other hand, we hear over and over and over from our patients, and probably people on the call do too, of nobody trained me how to get old. No one told me how to adapt. You're constantly adapting when you have complex chronic conditions and you're older. Your friend network is changing all the time. Your abilities are changing, including improving. You can improve. We can improve our muscles and our mindset and everything right up until the last months of life. But some kind of wraparound preventive expectations and referrals to kind of a wraparound care, I think, would be a really good thing to do with primary care. And then also to build on Mary's point of that it's not just doctors and nurses, there's many other possibilities, including community health workers. There's other possibilities for where the visit takes place. It could be by email. It could be by an iPad chat. Once we are working through all of the billing and the regulation for that a lot of times people shouldn't have to come. If they've got a 5-minute question, maybe it takes a 5-minute answer, and it can happen at 8 a.m. to someone. Once we figure out all the billing for that, I think that primary care could be primary the way it should be.
Okay, great. One of our participants asked a sort of complex question. This person really feels like it's important to engage our state and federal legislatures to help us champion this senior healthcare policies and our nursing policies. Have you thought of some ways that maybe we could be working with folks that can make some legislative differences, things that maybe we can do as we identify opportunities for some big changes?
So that's why I came to AARP. Because I am in charge of policy research, but I call ourselves a think and do tank, because we have this whole other arm of advocacy leaders in the nation, in the capital, but across the country. And these individuals are eager to work with nurses. That's part of what we've done with the Center to Champion Nursing in America, is link them not only to AARP, but to other advocacy and doers, I'll say, that can take the work that nurses know, whether it's research, practice, different model education, and bring it into the policy arena where that makes sense to do. Not everything is policy, but certainly we need to change laws around telehealth. For example, talking about technology, there are real limits to that. Nurses in one state, can they be talking to patients and families in another state? There's a lot of barriers to do what we really think can be done. So we're working very actively on bills around caregiving, around telehealth, around scope of practice for advanced practice nurses, many nurse delegation, making sure those community health workers can function without so many barriers that they really aren't able to do that. But I believe that you can find your state nurses association, you can find different professional nursing organizations that are engaged, as well as these different non-nursing, I'll call them, advocacy organizations to partner with.
Susan and I had a great chance to put this into action. This is now a long time ago, 8 years ago, Susan, around the Affordable Care Act, where AARP identified care transitions as one of its top 3 priorities. And we worked as a team, multiple of us, tirelessly working with staff on the Hill to make evidence-based transitional care a core element of multiple provisions of the Affordable Care Act. And at a local level, there's nothing we do in terms of projects thinking about how to accelerate evidence-based approaches and policy without thinking about who are the policymakers at the local level, state level, who should be part of our advisory group. Positioning nurses to be on the groups that, some of us have had a chance to be on, MedPAC or the National Quality Forum nationally, but starting at your local, and as you were reading in the New York Times yesterday, states are where much of the action is around healthcare. There's enormous opportunity, and I would encourage each and every one of you on this call and all that you can spread to recognize your voice must be heard as these deliberations about change unfold.
I think that Susan and Mary nailed it. I'll just add briefly that common sense solutions that improve health and decrease costs are something that nobody is against. Republicans, Democrats, and green people, purple people. It's all, if you can frame your work in terms of saving money and improving lives, there's no one who will be against it. And no one's against nursing either. There's a lot of opportunity here for spreading the work.
Okay, great. Those are great comments there. Another question is, do you have some suggestions for connecting to those community resources? A couple of you mentioned some, but maybe some more specific ways or organizations to look for in our state and or our community.
I found when I was a brand new nurse, pretty much, that joining my state nurses association was incredibly helpful. I learned a lot from mentors there, but just everyday nurses that were interested in, frankly, how a bill becomes a law. You might have learned it in 6th grade, but you need to be refreshed so that you know where the points are that you could testify. I started that way, like writing up the evidence, and learned a lot about how to make it more consumer friendly. Because the legislators themselves are not used to all this technical language, nor are their staff people. So there's a real thirst for that expertise to come forward, just volunteering. I did it that way, but there are different organizations. There's the League of Women Voters. There's all kinds of opportunities to find what makes sense for you. So where are your passions and who do you know? Getting on boards is a big deal. We've worked on that at the center, getting on local boards, school boards. Nurses are school nurses and occupational health nurses, and lots of ways that they can interact.
I would just add, I was a lobbyist before I was a nurse, and I became a nurse because I took nurses around Capitol Hill and really fell in love with what it sounded like they were doing. But from that background, just a reminder that the legislators and the community groups we deal with have a lot of different things they have to know about. And so we tend to get really down in the weeds, don't use acronyms, don't assume anyone knows. People will say, what's the difference between welfare and Medicaid? And you'll think, what? Of course, but just don't assume anyone knows anything and frame things as broadly and as positively as possible.
Oh, that's a great suggestion, Sarah. That's great. So the next question, do you have some suggestions? No, excuse me. That was our last question. I'm going to just blurt out a question here for Susan and sort of building upon the consumer perspective and improving functions of the conversation, really looking at the home alone research example. I think you mentioned that earlier, looking at what it is nurses can contribute and participate in when a patient who's going home alone.
Right, or home with a family member who then is alone with thank you. And we are updating that research. There'll be a new Home Alone 2.0, I guess we could call it. We need a better name, I suppose, in April. So that'll have more information that also looks at multicultural issues, generational issues, so and specific like special diets and things of that sort that we're getting. But that research was a really good example of translating, as Sarah just said, making it simple. These are my advocacy colleagues, into actual policy now in 40 states and territories, very simply, that nurses are very much involved in. How do you identify a family caregiver? Have that person, and this is any age, by the way, and any diagnosis, have that person's name in the health record. Involve that person in the care to the extent the patient, of course, and the family wants to be involved, and teach them how to do these things. You know, our old-fashioned teach back. Let's bring teach back, right? And then how do we make sure that it isn't a shock that somebody's going to be discharged as soon as possible, laying that forward for them on how that's going to be done. So that is now policy, and we're now looking across the country for promising practices. What are nurses and others doing to make that possible? So I think nurses hold the key to so much. They are, as we all know, on the front lines, but they need to realize that patients and family caregivers often have no idea what to ask them. So we are very good, I think, about answering questions, but if people on the phone can get the word out that they don't know what they don't know. And so anticipate, that's another old-fashioned term, anticipatory guidance, what they might need to know, that, you know, it's second nature to all of us now because we have all that knowledge, but try to remember when you didn't know all that stuff and what people might need to know.
Yeah, that's great. That's great. So we do have I have a question regarding telephone-based disease-specific management. How do you see that fitting into the transitional care model? And specifically thinking about depression, anxiety, care management with patients who have got complex needs.
Well, the whole integration of telehealth is, I think, central to being able to spread the reach and access of this growing population of people living with complexity, providing them with access to services. Though it does need to start with a really rich understanding about what people's needs are and how they can be met. And I think that's, again, where the playbook and evidence is helping us. It's helping us to know when is it that an in-person visit is central. I mean, you do not get to know what's going on in a person's home through a telephone call. And yet, you do need to know what's going on in a person's home if you're going to position them to be able to address the challenges that they're confronting or the environmental issues that they're facing every day that might get in the way of their care. So getting into the home has to happen. Maybe we'll have technology someday that will allow you to visualize a home and make decisions. But right now, that kind of work. But then what is it that could be done to supplement? When is it that a telephone call can really be used to reinforce teaching that has been done and make sure people are on course, or creating access, availability to telephone questions that people might raise. So I think we're in an era now where we recognize it's the integration of human and technological responses that are individualized to what Mr. Smith or Mrs. Jones needs at a point in time. And I'm very excited to see the advances that we expect to be happening, certainly with the Chronic Care Act, Bipartisan Budget Act of 2018, enabling Medicare Advantage programs to expand telehealth, to expand the way that we think about bringing community-based resources, enabling them to be accessed. I think we're in a very different era. So to me, it's integrating both to meet individualized needs that it's going to be the solution of the future.
And just one quick addition. I mean, Mary completely nailed it. But sometimes people try to cut home visiting because they think of it as expensive. But I think we would probably all say it's priceless, at least the first visit, as Mary was saying. And that as nurses, we should advocate for being able to see that whole home environment, the interpersonal dynamics. You see, if the spouse is jumping in on what the wife was trying to say, or and that those things are priceless, but they're trying to wrap telehealth around what we think is the best care in the home. We shouldn't sacrifice that.
There's a follow-up question that is really intriguing. really thinking about ways that technology could continue to help us support the telehealth component. This person has had success in giving patients cell phones and then having graduate nurses reach out to patients who are at home by themselves every day, checking in on them, checking on their meds and stuff. Is there some way that maybe this could be automated to help patients sort of stay connected, even telephonically or telephone-wise?
I would say yes, and maybe my colleagues would mention that. I think there are a lot of developers, a lot of electronic vendors that are trying to figure out what can be sold, frankly, created and sold, that not just individuals would purchase, but insurers, Medicare would pay for. We're really on the brink of that. Mary mentioned the Chronic Care Act, which is really important because it does at least allow the managed care, Medicare managed care, that we call Medicare Advantage. In that world, much freer use of telehealth. There's still some concerns in the fee-for-service world, in other words, outside of managed care, about opening up the floodgates, they feel like, to all of this technology in terms of costs. So on the policy side, we need to be working on making telehealth possible, reimbursable under Medicare and others. And on the technology side, we have to keep looking for the best solutions that people can use and understand. And we always think, we meaning AARP, not me specifically, keep saying to those who are creating them, you've got to work with the users, work with those who are in the home, work with the family caregivers, work with consumers, especially older adults in this world, about what they need, how can they get what they are able to use.
And not to assume that an older adult is an older adult is an older adult. There's such a range.
Yes.
There's no simple solution. And we are a very heterogeneous group of older adults, for example. And so being able to understand, for what group of people would a kind of automated response meet their needs for a relationship, for the kind of communication they need, and for what group of people will it be totally ineffective. And that's part of where, the kind of work that we do in building evidence and understanding individuals and understanding what it takes to really have the kind of relationship, trusting relationship that is central for any kind of success in the work that we do. We have to test it and adapt it. And I think you'll find multiple solutions can be adapted, but they need to be tested with a very heterogeneous group of older adults or young children.
Right. They need to be individualized. And again, going back to some of the old verbiage, but really thinking through, nurses do that very well. Thinking about one patient, assessing a patient, one patient at a time, and what can this patient do? What can this patient learn? Those kind of things. So opportunities to really individualize what it is that each complex patient needs.
Just really enabling that.
I'm sorry, Mary.
No, I just said really seeing as Susan was saying, the patient, the family caregiver, as you're co-designing with them the solutions that will best meet their needs.
Okay, one last question here. Actually, I'm gonna point it to Sarah. How medical assistants how can we include non-medical services?
Right. So Mary addressed that a little bit, and Susan in terms of the Chronic Care Act. But just to underscore, the Medicare traditionally has only paid for what they think of, kind of disease specific. It was even a fight to get them to cover cholesterol testing, for example. It was a very acute care, reactive view. And with this Chronic Care Act and with the recent guidance from the government to Medicare Advantage plans, that they can cover direct care workers, for example, if that's needed, and home modifications, things that we know improve people's health, but that haven't traditionally been called medical. And with our capable model, we've been able to show that, working on things like someone being able to take a bath decreases hospital utilization. And so we've got evidence to show that what doesn't perhaps seem medical when you're providing it is medical in terms of reducing medical utilization. And so the Medicare Advantage only covers a third of older adults. Medicare fee-for-service is the other 2/3, and that's changing rapidly. But we're hopeful that every financial mechanism will start to understand what nurses can do, what occupational therapists can do, what handyman people can do, what social workers can do to raise the level of health for all people with complex chronic conditions.
Okay. All right. Well, thank you so much. We've got about 10 minutes left, and I think to close, it'd be great if we could just maybe kind of go around this virtual room and ask each of the panelists to provide a short takeaway from our discussion today. And I'm gonna start with just a couple of things that I jotted down. I jotted down that Sarah mentioned that really saving money and improving lives, nobody's going to disagree with that. So really keeping your verbiage, whether you're talking to industry or the private sector or non-hospital people or legislators, really keeping that in mind, keeping that verbiage centered around that. And also working with the people who are actually using the service. Really understanding that individualization is very key, especially in complex patients. And the last thing that I wanted to just really think about or to jot down was really encouraging and maybe even looking and testing processes where primary care physicians and or offices could really think through what's going to happen when the patient goes home, not just who the next patient is, but really thinking through what that patient is going home to or with or for, so that you can really understand what that patient may need even a week from now. So anybody else like to mention a couple of takeaways?
Well, I'd like to credit my colleagues, both of whom are creative researchers in the think and do model that I love so much, but they both have policy backgrounds. You heard Sarah say that she was a lobbyist first, and Mary was a health policy fellow. Mary, I think that's the correct term, years ago, and has also led teams bringing in like economists into the early stages of research so that we can, those researchers on the phone in particular, so we can create models that we expect to translate and expect that hopefully policymakers will consider funding. Otherwise, we have a lot of pilots that it's hard to move it out further. So that's one thing I would say. And for those in practice and in education, to really think about what you can bring, how, as Mary said, your voice to the table. You don't have to be a lobbyist. You don't have to know all of that. But who can you find to team up with for something you're really passionate about? It's got to come from your experience and your passion. And teaming up with others can be a lot of fun, for one thing, and also incredibly effective.
All right, Mary or Sarah?
Well, first of all, I couldn't think of people that I'd rather team up with to accomplish anything than Susan and Sarah. But I think my key takeaways about this is that, I think we should be extraordinarily optimistic, even in the face of the growing complexity, rapidly accelerating complexity of needs of people, optimistic about where evidence has positioned us nurses as key members of the healthcare team. And so now the challenge is, I think, twofold. One is to make sure that everybody knows we've got a great starting point. We've got a great foundation upon which it is that we can deliver the gifts that we have to patients and family caregivers and communities. The other is that I think, and this would be a challenge, when we had this think tank a couple of months ago and brought in all these thought leaders from all different perspectives to say, what is it that needs to happen next to accelerate, not just using the evidence? And they said, we need to have a national dialogue with people, patients, communities, to help us to understand what it is that truly matters for them and have their voice help us drive future change. And so I would encourage all of us to think about how we could really move that kind of conversation so that everything we do front and center is guided by the people we serve.
Great.
Thank you, and thank you for this chance to be on with each of you. And I would say that just a real shout out to all the nurses on the call and the people who work with nurses, that this is our time, as Mary and Susan have been saying, and that take all the communication skills that you have with patients and families and employ them with your community and your policymakers, because we know how to communicate. That's what we do. We know how to educate. We know how to look at people in terms of what drives them and what motivates them, and that's exactly the same for changing policy. It really is. There's no mystery to it. So this is our time, and this is the time for treating the whole person in terms, including their social conditions, and it's a very exciting time to be involved.
All right. Well, thank you so much, Susan, Mary, and Sarah, and all of you participants who participated on the call. We're so glad that each and every one of you have been here. This has been a very encouraging call, and I hope you got some ideas of things that you can do in your own community. I'd like to thank again the 6 foundations that supported the development of the playbook. And also I'd like to remind you as participants that stay in touch through the playbook website. Again, the website is bettercareplaybook.org. Lots of great resources there that these ladies have mentioned, and lots of opportunities for you to stay in touch with others that are doing great and mighty things for our complex patients. So have a wonderful afternoon, and thank you all.
Thank you, Kathy.
Thank you.